Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. On today's episode of 1 p.m., sit back, relax, and listen to JT take us through the first principles of hypertensive disorders in pregnancy. Over to you, JT.
Hello, everyone. Welcome back to another episode of 1 p.m. First Principles of Medicine. My name is JT, and today I will be your topic master. Now, this topic that I'm talking about was related to a case that I saw at King Edward Memorial Hospital, and Dr. Ruvi Michero. She kindly gave me a quick bedside tutorial about this topic, the hypertensive disorders of pregnancy.
Wait, so we're getting your...
Secondhand?
Yeah, secondhand.
Secondhand, yeah. So it's probably diluted a bit, and then, just for our stupid questions only podcast. Okay, so...
Stupid question. Oh, he's changing the title now.
No, that's our slogan. It's a good slogan. Okay, so as I like to do when I'm the topic master, I like to ask everyone some stupid questions. So when we talk about the hypertensive disorders in pregnancy, what kind of disorders are we talking about?
Let me guess. Is one essential hypertension?
That's correct. Yeah. The pregnant woman might have already had hypertension before.
Cool.
But they were only diagnosed when they were pregnant.
Okay.
Yeah, good. Now there are a few more. Dan?
Pre-eclampsia.
Pre-eclampsia. Good. That's the big one that we're going to talk about. And Adian, because you're not on Obs and Gynae,
I'm not on
what
Gynae.
can you derive from pre-eclampsia is another hypertensive disorder in pregnancy?
Wait, say that again. But
So
like
Dan said
dumber.
pre-eclampsia.
Yeah. Eclampsia?
Eclampsia.
Okay.
Does anyone know what eclampsia means? If we go to the etymology of the word,
Eclampsia.
eclampsia itself. Yeah.
I was just going to say something about seizures, but...
Something about seizures. Yeah.
Don't know. Let me guess.
Don't know.
Something Latin. Something
It is
which
something
JT
Latin.
has
Yes,
learned.
of course. Then you have to know the reason why. According to Wikipedia,
Love it.
eclampsia means lightning. And so I assume, this is me just guessing, just refers to either the visual phenomenon that you get in your eyes, because you get blurred vision or you get dark vision, or it refers to the lightning-like seizures that you get as a result of eclampsia.
Okay.
There's actually one more, hypertensive disorder in pregnancy.
Gestational hypertension?
Lovely.
Wow.
So that's the umbrella
guys,
term
I
of
got
the
this.
hypertensive disorders in pregnancy. Now let's hear it again. What are the different hypertensive disorders?
So to summarize, you can have hypertension, which can be subclassified as essential hypertension or secondary hypertension.
Yep.
You can have gestational hypertension,
Mhm.
you can have pre-eclampsia, and you can have eclampsia.
Yeah, good. Yeah.
Cool.
So we're going to go on to the historical understanding of pre-eclampsia or eclampsia itself.
Mm-hmm.
So for as long as humans lived, females have become pregnant. So this
Yes.
condition we've actually known about for almost 5,000 years.
Right.
So 3000 BC. And we have writings from people from all continents. So China, India, Europe, Africa. Hippocrates was one of the first to document about this condition. So this is related to one of the things that we can see in medical notes. Preeclampsia often has a short form of what? What do we usually see it as?
PE.
Not PE, actually.
Oh, it gets confusing.
Not PE, actually.
PET.
PET. And what does the T stand for?
Don't know.
What does PE stand for?
Pre-eclampsia?
Yep,
Is
and the
it
T stands for...
Tox-
Yeah, go ahead.
I think it's like, I can't remember, toxicity.
You're right.
or
Toxemia.
Toxemia.
Yep. And that is actually a bit of a misnomer because what's the defining feature that you were talking about just now? The eclampsia.
Seizures.
Seizures. And so people used to think that the T, the toxemia, was the cause of these seizures. Really, it is something else that's causing it. So it's
Okay.
not the toxemia that we're thinking about.
Yeah.
But 2,000 years ago, when we had really little understanding of medical knowledge, why would someone think that you had seizures, especially if you were believing in religion?
Devil.
The devil, right?
The devil.
Something's wrong with your blood. You must be a witch. And that's why people thought that at the time, toxic things were the cause of eclampsia.
Right.
But then go into the 18th, 19th century, then we find out that, there's actually protein in people's blood. So proteinuria was another distinctive feature of preeclampsia and eclampsia.
Right.
Yep. And then afterwards, we actually understand that the key part in pregnancy is the placenta.
Yeah.
So it's actually due to a disruption of the placenta, which then leads to the features that we know now of pre-eclampsia and eclampsia.
Right.
I was about to say, can you rule out the devil with a CT scan?
Yeah, so the little background story to
Okay.
preeclampsia and why we still write it as preeclampsia toxemia, PET.
Could it just be a thing where PE was already taken, so they just added a T?
But then why they choose a T?
Was PE like pleural effusion as well then, or?
Yeah.
Yeah.
Oh, true.
Okay. So that was our little
Embolism? Yeah.
10-minute historical background into the different hypertensive disorders in pregnancy.
Gotcha.
Now for some first principles.
Yeah, love it.
Okay. So the first of the first principles relates to the etiology of preeclampsia.
Yeah.
And that was related to this context I gave you earlier. What was the thing that we understand now to be the main cause of these hypertensive disorders, Jason?
So I think the main cause of preeclampsia is just like an endothelial dysfunction, which no one really knows the cause of.
No, go back to the historical context I talked about.
Okay.
Not your own
It's not
understanding.
the devil. Something
Not
else.
the devil.
Not the devil, though.
It's always the devil. Okay. Then.
It is endothelial dysfunction,
Yeah.
but specific to what structure in the female body?
Le placenta?
The placenta, yes, exactly. So this was one of the key things that Dr. Ruvi emphasized for me, and I think that helped me understand everything, is that these hypertensive disorders are not due to chronic hypertension, right? It only happens in pregnancy because there is a placenta. Yeah, so there's endothelial dysfunction and something wrong with the placenta and the arteries of the placenta, and it's causing this hypertension.
Gotcha.
So-
Sorry, go, Jason.
No, so to summarize, placental dysfunction is the main contributor of preeclampsia.
Yeah.
Or the main
Yeah,
cause.
good.
Okay.
And if we're going to go to a bit specifics, there are two main mechanisms. One is the vasoconstriction of the arteries that go to the placenta,
Right.
and then the other one is the microthrombosis.
Right.
So these are the two key mechanisms that we can use later for the clinical features. So remember these first principles.
Can you explain what those two things were?
Vasoconstriction.
Yeah.
So then you get
Constriction of arterial.
Yeah, and
Yeah.
you get narrowing of the blood vessels,
Yes,
so
and
poor
then-
flow. Yeah.
and then that probably causes endothelial injury, which then causes microthrombosis to occur.
yeah.
And
Yeah.
I assume that leads to the production of various mediators which go into the maternal circulation and cause the systemic signs and symptoms
Yeah,
of...
and also
Yeah.
in Obs and Gynae, we always like to think about there are two patients that we want to worry about, right? So, Adian, what are the two patients that we care about?
The mother and the fetus?
Yes, lovely. So,
So-
then you're going to get ischemia and oxidative stress to the placenta, which then causes problems for the mother and for the baby.
Gotcha.
Okay.
Yeah.
s-
So the key thing is
So the key things, you got placental dysfunction.
that is the key thing there.
Yeah.
Yeah.
Okay.
Done.
All
Sorted.
these hypertensive disorders, apart from the essential hypertension, is due to placental dysfunction.
Yeah.
Okay.
Gotcha.
Cool. I like
Yep.
it. Nice, simple.
Good. All right. The second first principle that I want to raise goes back to the umbrella terminology that I was referring to earlier. So hypertensive disorders in pregnancy. And we're going to give you a bit more definition, Adian.
Love it.
So essential hypertension is all the hypertension they get before pregnancy. Gestational hypertension is one level up. And what gestational age or week did I mention earlier that we used to classify as gestational hypertension?
20 weeks.
20 weeks. Good. Okay. So
Halfway through a pregnancy. Because 40 weeks
roughly,
is...
yeah.
Yeah.
Oh, yeah. Good. So Dan,
okay.
that goes on to the definition of pre-eclampsia, right?
Can you explain the difference between gestational hypertension and preeclampsia?
Dan, why don't you give a go?
Both occur after 20 weeks.
Yes.
Good.
Gestational hypertension is only hypertension. Preeclampsia is hypertension plus proteinuria and plus the other signs of
So-
body dysfunction.
Yeah.
So,
That makes sense. Yeah.
so could you think of it as a severity thing? So if you have gestational hypertension, you just have high blood pressure. But then if you have preeclampsia, you got hypertension plus
Other shit.
potential other signs of dysfunction.
No, let's not say other shit because there's
Yeah,
the
so
P stands for what in preeclampsia?
the proteinuria. Right.
Good.
So you have proteinuria.
Yeah.
And or other signs or symptoms of organ dysfunction.
Good, which
Yeah.
is normally what you get with chronic hypertension
Yeah, sure.
anyways, but it's the
Yeah.
different mechanism.
Sure.
Yeah.
And then the worst one you can have
Yeah.
is eclampsia,
Yeah.
which you have all of that. So you got high blood pressure, you got signs of organ dysfunction secondary to the dysfunction of your placenta.
Good. Don't
and
miss that.
you also have seizures.
Seizures.
Doesn't sound good, guys.
Yeah.
No,
Doesn't sound good.
That's good. So you've had those signs in the
Yeah.
past, and then eclampsia is the seizure disorder that comes after all of
Right.
that.
Yeah.
Yo.
Yeah. So maybe
It's the icing on the cake.
Love it. Yeah, cool.
Interestingly, you can get eclampsia after birth as well.
That's not good.
Yeah.
Can you?
You can get it after. There's like a time frame, I think. That's
Ah.
related. I think it might be related to. Oh, yeah, because your placenta is
eclampsia.
still there.
Yeah.
Okay.
Oh, okay. So as soon as you extrude that placenta, then theoretically you will no longer have these things.
That's correct. That's very correct.
Spoiling it, man.
Yeah.
That's very
Spoiling the
correct.
management.
Good. All right.
Idiot, man.
Give
And
it
then
birth.
the third first principle that I want to give more like a little trick now. Have you heard of HELLP syndrome?
Oh, yeah. I've seen it written in notes.
HELLP syndrome. Okay. Now these refer to the clinical features that you can see with severe pre-eclampsia.
Okay.
Okay, so it's kind of separate to eclampsia.
I kind of
All right.
think of it as like a subtype of preeclampsia.
Okay, yeah.
Is that
All right,
okay
let's
to
do
think of it that
yeah.
way?
But I'm just using that as the mnemonic, as one of the key signs and features that you can see.
Okay.
Okay?
With preeclampsia.
Yes, if according to Jason,
Okay.
it's a subset. Okay?
Yeah. Okay. Go for it.
All right.
Yeah.
So let's go again. The first key principle was the placental dysfunction.
Yeah.
Yeah.
HELLP stands for three separate things.
Yeah.
H stands for what?
I think it's hematological.
Hemolysis.
Oh, hemolysis.
Hemolysis. So one of the investigations you can do is red blood cells are dysfunctional.
Is that
Yeah.
is that because of the microthrombi and then
yeah.
the red blood cells get mechanically damaged going through those microthrombi?
Yeah, exactly. Yeah,
Okay,
very
so
good.
H
Okay.
is for hemolysis.
Okay, the second of HELLP is EL. Elevated something.
Elevated protein.
No, EL.
Oh, elevated LR.
L stands for an organ inside your body that's
Liver?
somehow... Yeah, good.
Elevated liver.
Enzymes.
Oh, okay, cool. I was going to say, your liver moving into the thoracic cavity.
So elevated
Liver-
LFTs.
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 Sure.
So specifically the aminotransferases.
Okay.
The AST and the ALTs.
Okay.
Yeah.
Okay.
Okay?
Yeah.
And then the last one is LP.
Lumbar puncture? No.
So low...
Platelets.
Platelets. Good.
Because you have thrombi. So you have
Yeah.
thrombocytopenia.
Yeah, good. So these are the cool mnemonic that you can use.
Ah.
Okay, so to summarize, H is for hemolysis.
Good.
EL is for elevated LFTs. And LP is for low platelets.
Good. All right. So this is a good segue into the clinical features that we can see with hypertensive disorders in pregnancy. So let's just focus on preeclampsia as the main thing that we're talking about today.
Yeah.
Okay. So let's go through a systematic approach from head to toe. So if we just look at the head, what kind of things do you think will occur that are secondary to the placental dysfunction that we were talking about, and also the hypertension?
I don't know how it relates, but I thought headache.
Headache,
Starting with
yeah.
the head.
So can we try to think of the mechanism there? And again, this is very acute, severe hypertension. It's not chronic hypertension that we're talking about. Yeah.
I now figure it out. So with the hypertension, if you got very high blood pressure, that can cause edema
Good.
due to the increased capillary hydrostatic pressure,
Yep, sure.
which cause fluid leakage, which then leads to
Compression or
compression,
whatever. Yeah.
causing headache.
Yeah, good. Lovely. What else could you get eventually?
Well, if you've got cerebral edema,
Yeah.
things like confusion, I suppose nausea and vomiting might come
Altered
before
mental
that.
state.
Altered
Yeah.
mental state.
Yeah, good. And then the final stage of the CNS that we were talking about will lead to eclampsia, Adian.
The seizures.
The seizures,
So
yeah.
seizures, I'm guessing it's because of like raised intracranial pressure. Because of edema?
Yeah.
Okay.
And another thing that is somehow related to hypertension in the brain, it explodes. What kind of thing?
Aneurysm, a ruptured aneurysm?
Yeah, or it doesn't have to be an
Oh,
aneurysm,
just a
just a
rupture.
stroke, just a
Yeah,
hemorrhagic
rupture,
stroke.
yeah.
Yeah, so these are, if at the time, and I was taking the history at the time, I was like, have you had any seizures lately? Not a good question to ask, because if you ask that, you already missed the boat. The person's already
Yeah.
had eclampsia, and you're
Yeah.
pretty much too late for
Yeah.
management.
Yeah.
So I had a bit of a grill about that when I was asking the history.
Right.
Yeah.
Damn.
When I was presenting the patient, I was like, she hasn't had seizures lately. Of course not. Otherwise, why would they get the medical student to take a seizure history?
I mean, she could have had seizures from a secondary thing, not the preeclampsia. Could have been.
So
Epilepsy.
what is some investigation that you can do here specific to this CNS presentation that we're talking about? If it's cerebral edema, what's something that you can test? It's a neurological examination. What's something that you can do to examine this patient?
Like a cranial nerve?
Not something you do in cranial nerve. It is actual cranial nerve, so it relates to the second point. What will you do in cranial nerve? What are you trying to look for?
You're assessing all the cranial nerves? Like
What specifically?
All the cranial nerve? What do you mean?
Wait,
Like,
which nerve specifically?
That you will
Oh.
see a clinical feature on. That was related to the lightning that we were talking about earlier, the definition, etymology of eclampsia.
The optic nerve?
Yeah. So you get visual disturbances.
Yeah.
So you get dark spots or blurred vision, and that's
Okay.
somehow related.
Yeah.
I'm just going to guess cerebral edema. I think that's the easier way for me to remember that. Another thing that we try to do, also neurological exam, upper limb, lower limb.
Yeah.
One thing that we test for, what is something that we test for might be related to this cerebral edema.
Is it tone or reflexes?
The latter.
The latter.
Reflexes.
Yeah,
Okay.
reflexes. Yeah.
Yeah.
And I was very surprised. She brought out this tendon hammer for me to test on this lady. And are you going to get hyperreflexia or hyporeflexia? Hyperreflexia. Yeah. You're going to get brisk reflexes.
When's the last time you used that tendon hammer?
On that day when I was testing on this
I mean,
woman. And I was like,
do you know why it's hyperreflexive?
I think because you'll knock out the descending inhibition.
Yep. That makes sense.
Yeah, good. So then from head to toe, we've done the head, we've done the mental state, and the eyes.
But
Okay.
just on what Dan said, from my understanding, I think upper motor
It's upper
neurons
motor.
are more responsible for inhibition than
So
the
it's
lower
upper
motor
motor neuron.
Yeah, it's an
right?
upper motor neuron.
Yeah.
Sorry.
Yeah.
Yeah.
Okay, moving on. So again, hypertensive disorder secondary to placental dysfunction. Okay. Think about our lungs. What kind of symptoms or signs can we get with
Dyspnea.
dyspnea?
Yeah.
Yeah. And what is the mechanism behind that?
So you got hypertension,
Yep.
similar to the brain. You're extruding fluid. You get pulmonary edema.
Pulmonary edema. Yeah,
Yeah.
good. And another investigation we could do when we auscultate?
Investigation.
Examination,
Oh.
auscultation. So you can hear.
Yeah.
Oh,
hear.
yeah.
Crackles,
Yeah,
cause
good.
crackles.
Yeah, good. Lovely. Moving down, then we have our organs in our abdomen. What kind of pain do you think they'll have? Or, yeah, I'm giving it to you,
So-
but
so you get
where's the
some-
pain
So
and
either
what is the cause of the pain?
epigastric pain or right upper quadrant
Yeah,
pain
good. And what is that the result of?
from your liver, from some liver dysfunction causing pain.
Yeah, good, exactly. So the liver dysfunction, what kind of things do you get with the liver?
Hepatomegaly.
Hepatomegaly. In this case, do you think it's hepatomegaly or something else? You also get right upper quadrant pain.
So your liver is not producing enough.
So let's go back to HELLP
proteins.
syndrome. What does EL stand
okay.
for?
Elevated liver enzymes.
Where do you find these LFTs usually?
In hepatocytes?
Right.
Yeah.
So when they break up, when they die, then they get released, right?
Yep, so there's some damage to the liver.
Yeah. So it's more damage to the liver than hepatomegaly.
What
to the
causes
liver.
the damage to the liver?
It's the vasoconstriction and the microthrombi that we're talking about. They obstruct
Okay.
the liver
So you're like
sinusoids.
infarcting bits of the liver, maybe.
Yeah.
Okay.
And also the second thing I want to point out, it's a good example, is that you're not going to get hepatomegaly overnight.
True.
But with this, you are going to get this very suddenly.
So,
and that's why
yeah.
it's very important to catch this early.
Right.
And monitor the patient, because otherwise they can suddenly jump into eclampsia. And then finally, going down to the rest of our body, we look at our ankles and our feet. What do we see there because of this hypertension?
There you go, Dan.
Edema.
Edema. Yeah, lovely. Good. You pretty much got it. And then the signs, if we want to repeat the signs, what are the two things that are specific of the definition in preeclampsia that we raised earlier?
Oh, you get high blood pressure.
High blood pressure,
Yeah.
and how do you investigate that or examine that?
Check blood pressure.
Yeah,
using
good.
Using a sphygmomanometer, guys.
When you
That's
do
good.
Obs and Gynae, you
Yeah.
all of a sudden need to use the manual one.
Why is that?
And
You
it
have
took
to do it manually.
Why is that?
Do you know how awkward it is to actually like hunch your back over and
Yeah.
like get in the right position?
Do you know-
like try to use the right hand to like which one do you hold your stethoscope with? Which one do you?
When's the last
and
time
then
you
you're
heard
like
a
looking to the
cough sound?
left and your neck and your lower back is giving way and you're like, am I going to
I think they're
diagnose this
talking to
person?
them as well. Yeah. Antenatal clinic, they just keep talking.
It's like I'm probably doing this for the fourth time in my life, guys. Please.
Why do they do manual, not electronic? Is there a reason?
budget cuts.
Sure.
I assume.
I don't know. I don't
sorry,
know.
in the ward, of course, they use the electronic,
Yeah.
but I think in the clinic, they just
I-
get the medical students to
They-
do things.
From my understanding, in emergencies, they even still do manual blood pressures because I think they can be a bit more accurate than doing it with the machine.
No,
But
sure.
yeah.
I think
think they doubt our ability.
Can you imagine in an emergency, everybody's yelling, everyone's talking, and you're there trying to listen to some cough sounds?
That actually
That's
happens
K1 then?
sometimes. That
What is the cutoff that we use for hypertension?
140
Over?
or 90.
Good, yeah. I've seen another cutoff, 160 over 110. But I guess let's just keep it simple. Just use 140 over 90.
Cool. Gotcha.
And when we do diagnose essential hypertension, right?
Mm.
What is the diagnostic criteria?
Is it like 2 tests 5 minutes apart or something?
Good, yeah, that's good.
You do
And
two
how about for these pregnant ladies?
Mm.
Any difference or the same?
Do you do like a blood pressure profile where you?
Let's go that later, but
Yeah.
there's also a definition that's based off 2 separate readings
Is
and
it 6 hours apart?
4 hours apart.
4 hours apart.
According to the thing I looked at, yeah. But I think it's just it has to be sequential, right?
So your med student has 4 hours to go and learn how to do a manual blood pressure and come back.
Yeah. Wait, Adian, this is. Be prepared. What court cough sounds are you listening for?
All I know is you hear it and you don't hear it.
All right, Jason. Jason, why don't you tell us about that blood pressure profile thing that you're just mentioning? What is that?
Yeah, it's something you always see in Obs and Gynae. I only learnt about it in Obs and Gynae. From my understanding, you basically measure their blood pressure every 15 minutes for 1 hour.
Yeah.
And yeah, you assess whether it's still high or if it's trending downwards or upwards.
I think you get their average.
Oh,
you get their
get-
average, and then if there's, but it's not you doing it. It's probably the midwife.
I was going to say, because if you doing it, in 15 minutes, you've only heard the first one, can't hear the second one.
Yeah. So the blood pressure is very important. There.
Yeah, gotcha.
Any questions there?
That makes sense.
Yeah, and I think that helps to reduce like white coat hypertension and stuff.
Yeah,
because
definitely. If you're doing serially.
They do it serially.
Yeah. Okay. And then the other key feature that we can try to investigate with pre-eclampsia, the P I was talking about earlier, is a key sign is
Proteinuria.
proteinuria. And what are the different ways that you can try to investigate this?
Dip that urine.
Dipstick? Yep,
Yes.
that's the least effective, I think, because you need an exact level.
Yeah.
You don't have to expect to know the level, but what's the gold standard thing that we can use?
Oh, I thought it was a urine ACR or urine albumin.
PCR.
Oh yeah, urine
Protein
PCR.
creatine ratio.
Yeah.
That's not the gold standard, but it's the most
Okay.
commonly used. The gold standard is not commonly used. Something you do over a day's time. A day is worth 24 hours.
Oh, urine collection over 24
Yeah.
hours.
No one.
24-hour protein
I've
collection.
never ever seen that.
Oh,
No,
God,
I'm
really?
just this. According to documents, this is the gold standard,
makes-
and according to that tweet that we had with
Yeah.
professor, I did ask him, and he's
The,
like,
the golden
it's just-
standard,
it's
which no
just-
one uses.
It's just in.
That is the gold standard for urine output in general.
Yeah.
Like it's 24-hour collection.
Yeah. It's just what was it called?
does that.
Inconvenient.
Ain't
or
nobody
just-
got time for that.
Yeah, and you probably take 24 hours to do the blood pressure, so I might have to collect the urine as well.
We just miss one
Yeah,
measurement.
that's going to help with blood
Yeah,
pressure. Put in a catheter.
Get that procedural signed off.
Exactly. Lovely. So we have all these things that we talked about, the first principles, the clinical features. Now we talk about the complications.
Yeah.
Okay, just quick run through and then we'll go to management
Gotcha.
and we'll be done soon. So again, 2 patients in Obs and Gynae that we want to worry about. So again, you can think about this in 2 categories. First the mother and then the fetus. Okay? So the mother, like the things that we talked about earlier, just to summarize, in terms of the CNS, you want to worry about headache, seizures, maybe a hemorrhagic stroke. The lungs, you're worried about respiratory distress that might then lead to acute respiratory distress syndrome. Yep. Third, the kidneys with the protein, what can that lead to?
AKI.
AKI or even kidney failure.
Yeah.
And then if it's very severe, you get your seizures, coma, that can lead to
Death.
death. Yeah. So now we talk about the fetus, okay?
Yeah.
Again, the first principle is placental dysfunction. What can that lead to in terms of the fetus?
Well, placenta provides the nutrients for the
Yeah.
baby.
Yeah.
So you could get some type of growth restriction.
Yeah, good.
The placenta is not providing enough
And
stuff.
what's the short form that we see on the computers that
I always forget what it's.
IUGR.
IUGR? Yeah, good.
Intrauterine growth restriction.
Intrauterine. Yeah. Yeah, good. Another complication?
Yes.
You are correct. And there's another thing. There's a technical term to this, but it's when the placenta gets ripped off.
Abruption.
Abruption.
Hmm.
Yeah.
Because the high blood pressure helps, it comes off the wall.
Yeah. So the bleeding into the placenta and then boom.
Ruptures off.
Yeah.
And then GG baby.
Jeez.
And also, it can be a huge risk for the mum because the placenta gets a lot of blood supply.
Yes, yeah.
I think it's 750 mils a minute or something crazy like that.
In the placenta, right?
Yeah.
Yeah. Yeah. So now we're just going to management. Shouldn't take too long. Yep. What are the things that we do? You have this mother with preeclampsia comes in.
Are we breaking it down to the fetus and the mother or just?
Let's just say both.
Okay.
Yeah. And what's the first step that we always do as responsible medical students?
Sorry,
A, B, C.
What?
It's easy
Take a
as
history.
one,
Take a
two,
history.
three.
Take a thorough history from this patient.
Good.
Yeah.
And what are you trying to assess for during this time? You might not know, but
I assume you're trying to assess for the signs and symptoms of preeclampsia
good.
that may put them at risk of eclampsia.
Good.
Or death.
Yeah, good. And what specifically are you looking for our friends who've done Obs and Gynae in terms of the fetus? What kind of things would you do there? There's quite a routine that you check for when they're in an antenatal clinic or when they're doing other
So,
investigations.
like, depending on the age, like fetal heart rate.
Yeah, okay. Yeah, good.
Um,
And what's that fancy thing that you put lube on the... Is it
The
lube
ultrasound?
jelly? Yeah.
yeah, ultrasound.
Oh, this is a weird question. But if you have a pregnant woman and you put your stethoscope on their abdomen, can you hear the fetal heartbeat? Does it conduct through the womb into
No,
your...
Usually you need to use a Doppler, which is...
Right, so you can't like auscultate the fetal heartbeat.
I haven't tried.
I haven't tried, but I assume it...
Try it.
I assume if they're using
I'll ask
the
midwives.
Doppler, it's probably because...
They probably
you can't
smack
ask-
you like, what kind of dumb question is it? I mean...
No,
I-
it is a good... Yeah.
I don't-
No
I-
one's actually...
I don't know.
They use the what's it the
Yeah,
tachometer,
CTG?
whatever it is. Yeah.
Cardiotogography.
So, like, overall, you've got things like ultrasound.
Yeah.
You've got CTG, which is
Yeah.
pretty much the heart rate.
Yeah.
And you've got... like, the... I don't know, ultrasound
The
and
technically
CTG,
called
like-
the non-stress test includes the CTG, and then the biophysical profile also includes the NST. These are just different measures that people can use.
Okay, I was
Yeah.
confused, but yeah.
Yeah, and it's all about just looking at the fetal movement, just to check if the fetus is still okay, if there are any complications there.
So this is basically just non-invasive
The first
scans.
step. The first step
Yeah.
is just to assess the maternal status and the fetal status.
Okay.
Yeah.
Yeah.
Okay. So, what's the second thing that we can do related to all these things that we talked about, the definitions of preeclampsia?
Order some blood tests.
Yep. Okay. Let's go to blood tests. What things would you
So for
try to
HELLP
get?
syndrome,
Yep. Okay.
so I don't know what test you would use for hemolysis, but
Full blood picture.
Full blood
full
count.
blood
Good.
count, yeah.
And then the next one.
So LFTs.
Good. And then
And then the last one, platelets.
Which is part of the full
blood picture.
Yeah.
yeah. What are some other things that you would do?
Could you do a coagulation profile if their platelets are low?
You can actually, and that was something else that we would do for the full blood picture. For the bloods.
UEC.
Yeah. And then what are you looking for?
Protein.
Protein. Yeah. Protein. Yeah. Good. All right. Then we've done the bloods. What else is quite urgent that the patient is presenting with?
High blood pressure.
High blood pressure. Yep. And so what would you do to manage this high blood pressure?
So keep them seated up. You can give them some medication to lower their blood pressure.
Yeah, good. And this is the mnemonic that was found on Ambos. Hypertensive moms need love.
Yeah.
HMNL.
Hypertensive moms need love.
So these are
So-
just the 4 names of drugs that we use. And the L is the drug that we use the most often, at least at King Eddie guidelines. And it's a olo drug. What's a drug that starts with L and ends in olo?
Labetalol.
Okay. Yeah, I'm still on bisoprolol. I haven't gotten to the L's yet. I'm still on the B's.
Isn't nifedipine the first line?
Okay,
Yeah,
yeah.
yeah,
I
I
don't
just-
know.
I'm
Yeah,
not-
could
yeah.
be, yeah. Let's just
Cal-
remember, easier to
Yeah,
remember,
yeah.
antihypertensive,
Calcium channel
labetalol.
blocker. Nifedipine.
That's
Yes.
correct, yeah. That's correct.
Yeah.
Yeah, good. So to manage blood pressure.
Wait, so what are those drugs? Can you just
Oh, okay, sorry, of course.
I don't know what they are.
Hydralazine, I think it's a vasodilator. I think it's-
Hydralazine.
I feel like all you have to remember is nifedipine and labetalol.
But we already said so.
Oh, yeah.
M stands for methyl-dopa, N is for nifedipine, and L is for labetalol.
Methyl dopa. Is that a dopamine?
Yes, and contraindication, you can't use it when they have anxiety and depression, if they have anxiety and depression.
and
Let's just stick with,
Cool.
and there, we'll just say
Done.
labetalol.
How do you spell that?
La-be-ta-lol.
Labetalol. The better lol, in fact. It's
Okay.
the better lol for pregnant women.
Sure. And then the third thing that we want to do, what's some key feature that you get in eclampsia, Jason?
seizures,
And what can you do to manage this?
magnesium sulfate.
Yeah. And it's an anticonvulsant.
Yeah.
Yeah. Now, the last management, which is something you alluded to earlier, and also relates to the first principle, these are hypertensive disorders secondary to what, Jason?
Placental dysfunction.
And so what is the one thing that you have to do in order to get rid of this preeclampsia?
Remove the placenta.
Delivery of the placenta.
Yeah,
is
delivery.
the only cure for preeclampsia,
Yeah.
for eclampsia.
Gotcha.
Yeah, good. So why don't we go ahead and summarize the management? That was basically 4 things that you could do to manage a patient with preeclampsia? One each?
In order or?
Yeah, go ahead.
Oh, shit.
You have the easy one.
You do an assessment.
Yeah,
The
okay.
History, examination,
Yeah.
mother and baby.
Yeah, okay, good. And
Yes.
what's the key thing that you're trying to look for?
With the gestational
Yeah.
age.
Good. All right. Moving on. Dan, what's the second thing that you do?
Control the hypertension.
Yeah, good. And what's the key drug that you can use there?
Labetalol and
Labetalol.
amphetamine.
Yep, okay, good. Moving on. Jason?
You want to help like seizure prophylaxis by
yeah.
giving magnesium sulfate?
And to finish it off, Aiden?
Depending on the risk and the benefit,
Yeah.
depending on the gestational age of the fetus, depending on the health of the mother, you might induce labor to cure the preeclampsia.
Why?
Because preeclampsia, guys, I don't know if you know this, is a result of placental dysfunction. Ergo, no placenta, no dysfunction.
Yeah.
Okay, thank you guys.
Okay.
We've finished our discussion
you're
on
good.
hypertensive disorders in pregnancy. If you want to know more, please check out our Notion document where you can find links to Anki decks made by Jason. And also, if you could, please leave us a like on Apple Podcasts, Spotify, and we'll see you next time. Boom, ruptures off.
Yeah.
And then GG, baby.
Hey 1 p.m. listeners, Aiden here with a few fact checks from the episode. At 10 minutes, JT points out that the symptoms of preeclampsia will resolve after delivery of the placenta. In most cases, the conditions will resolve within 48 hours of childbirth. However, there are rare cases where preeclampsia can develop up to 6 weeks after childbirth, also known as postpartum preeclampsia. At 25 minutes, I asked about whether we can listen to the fetal heart rate with a stethoscope. There are 3 main ways to monitor the heart rate of a fetus. First, using a Doppler ultrasound. Second, via CTG or cardiotogograph. And third, via a special type of stethoscope known as a Pinard stethoscope, which can be used from 28 weeks of gestation onwards. Thank you so much for listening to our episode this week. To get the most out of this podcast, check out our Anki flashcards and our Notion document. And for all your first principles, keep it right here at 1 p.m.